My name is Russ Sorrells. We got Kelvin Jones here from Prosthetic and Orthotic Institute. We are going to talk about suspension systems. So, new amputees often, first thing, ask the question, what system should I use? Should it be a pin system? Should it be a suction system? Should it be a vacuum system? So, today we're going to talk about the different system options that you have. Kelvin is going to explain the differences between those systems, also talk a little bit about socks and liners and liner options. We've got a presentation that we're going to share with you as well. So, Kelvin, um, introduce yourself. How long have you been a prosthetist?
Sure. So thank you guys for having us. I have been a clinician now for 20 years in prosthetics and orthotics. And as Russ mentioned today, we're going to be talking about two different types of mini suspension systems, specifically pin locking system and suction and elevated vacuum.
Excellent. So, what does an amputee need to know in the beginning? Because a lot of it, as I understand, is it about comfort? Is it about the level of your ability to walk? What goes into deciding which system to use?
A number of factors: the anatomy of the patient, how soon after the amputation we're seeing those patients. Research shows it takes about 6 to 7 weeks for a below the knee or an above the knee patient to heal with an amputation, and then we can start the prosthetic protocols. It's also determined by, again, the volume fluctuation, what the secondary health issues may be with the patient as well. Their activity levels help to determine what type of system.
And just to back up, what you said, you mentioned volume fluctuation. What do you mean by volume fluctuation?
So we have the lymphatic system in the tissue where our body is predominantly made up of fluids, right? And those fluids initially after the amputation are one of our top priorities is to educate patients on the amount of fluid or swelling or edema, if you want to call it, that is in the what we call the residual limb, which is where the amputation occurred. This is the path of least resistance for our bodily tissue and fluids to accumulate. And so we have to do early education on proper wear with a compression stocking or a shrinker for our patients. And this helps reduce that amount of swelling and fluctuating edema. Um, I like to sum it up to our patients and explain it to them as like the stock market. It could be very volatile, it could be even, but during that first 12 to 18 months after the amputation occurs is when we see the most volatility with the residual limb of fluctuating edema.
And that's going to impact comfort significantly, right?
It's going to impact comfort. It's also going to impact the fit of your prosthetic socket, which is when we're fitting a prosthesis, we want to increase and give back proprioceptive feedback for the patient. What does that mean? That means I want to create an environment in a prosthesis that's going to allow our patients to feel like it's part of them. The more the prosthesis feels like it's part of them, the higher activity they're going to have, the higher confidence they're going to have with walking and ambulating, and the more confident they're going to be when they're walking and ambulating, when they feel like the prosthesis is a part of
Okay, excellent. So let's talk about, we've got the patient has had an amputation. What happens right after that amputation has occurred? What is the next thing that we should expect as it relates to, or for the patient?
So the healing process is important. With your surgeon performing the amputation, is of the utmost importance that you follow their protocols and getting the residual limb to heal properly. That's obviously being safe at home. One of the highest incidences of folks having to come back in the hospital after the amputation occurs is having falls. And with that fall, we have what's called a dehiss or a wound opening where the amputation occurred because they've fallen and they maybe bumped it, they've fallen and put too much pressure on the residual limb. In other words, it opens back up, have to be readmitted to the hospital. So that is important to remember initially right after the amputation. That is the number one aspect, is to prevent infection and to allow the residual limb to heal properly.
Excellent. So now they've healed, and what is the next step? And then is this when you start to determine which suspension system is going to be most applicable for or appropriate for the patient?
Sure, that's when we start that process, is to evaluate our newer amputees, especially below the knee and predominantly above the knee as well. We want to start them in a pin locking system the majority of the time, because it's easy to take on and put on, put on and take off, I should say, don and doff.
Okay.
That's what we like to use to define that. Uh, with the pin locking system, it's easy, it's consistent. You can put it on the same way every day. It does require some good dexterity to get the pin mechanism lined up, like we're going to talk about here later when we look at anatomy and the different systems. And then we can also do our suction suspension above knee for patients as well, and below the knee, predominantly above the knee for suction suspension, though, with new amputees.
Okay. Well, that's a good start. I'm going to share a screen here that presentation that we have created and that you created actually. So to talk through some of this. So first off, we talk about the liner. So explain the liner and why it's important, what it does, what's its function.
Sure. So when we are in our sphere of influence in prosthetic liners, we're looking at really three different types of materials for our patients. The first one is silicone. And so with silicone, I've brought samples of those today. When we talk about silicone liners, and many folks will wear a silicone liner, this could be, actually, it could be made of a white silicone material, or it could come in a clear material like this one here is. Let's talk about the properties of silicone and how it benefits our patients, right? So those properties of silicone is that it's thick, it's very stiff in durometer, it's more of a funnel, right? We're going to put the residual limb inside of the silicone liner, and as a result, what this does is kind of forces the residual limb to follow the shape of the prosthetic liner. Who is this liner predominantly placed on is our below knee and above knee amputees who have really no secondary issues with, hence, diabetes, any wounds that we're concerned about. We really have to have a nice firm residual limb for this type of liner. I prefer that as well. You talk to 10 different clinicians, we're going to have 10 different opinions, but in my opinion, the silicone liner works best for the residual limb that is able to go inside of a prosthetic liner and be held there. As you can see, when I hold this liner up, it's very stiff.
Yeah.
Not very flexible. And hence what that means is that it's not super skin friendly. You're going to conform the residual limb to take the shape of this liner.
Okay. So it could cause skin irritation versus some of the other options?
Not necessarily skin irritations as much as we are forcing your limb to conform to this liner, whereas our other two liners will conform to the residual limb. So we're forcing the limb to fit this cylinder, and our other two liners we're going to talk about this morning with polyurethane, for example. When we look at this type of liner, as you can see, it's very, very flexible, very skin friendly, in other words. When you're donning this type of liner, from a molecular standpoint, we don't want to get too far down into the details of this for our patients. But just to help explain, as you can see, when I press my finger inside this prosthetic liner, it actually thins out. Whereas with silicone liners, they're not going to thin out at all. They're going to force the tissue of the residual limb to thin out. When I create a socket for the polyurethane liner, this allows the liner to thin out where the bony prominences are. And if you're a below knee amputee, especially, when you're wearing a prosthetic liner and your fibula head or your distal tib on the anatomy here, the distal tibia gets inflamed, you want relief in those two areas because those are the two most bony, prominent bony aspects of the residual limb, especially below the knee, that we have to create space for.
And because that's where your body weight is as you're standing on your prosthesis.
Correct, and that also depends on what type of socket we're using. We could be using a patella tendon bearing below knee socket, which we could talk about, or we could use a hydrostatic total surface bearing socket, which is created under vacuum. We use those predominantly with the urethane liner to disperse the body inside the liner and bony prominences. And
Okay. So what about the copolymer liner?
so third is copolymer or like a thermoplastic material. So when we look at this, and by the way, when we're talking about these three specific type of liners, we're talking about the molecular makeup. And so the urethane is stretchy, really thins out with the bony prominence when it's pushed upon that. The silicone liner forces the residual limb to conform to the material. And then last one that we'll cover today is the polyethylene or the copolymer thermoplastic material. It's very skin friendly. I choose to use this type of liner on our newer below and above knee amputees because of those factors I just mentioned. It's very skin friendly. It's easy to don and off, take on, put off, or put on, take off, I should say. It's very easy for the patients to manipulate and to put on their residual limbs. These work well with pin locking systems as well. A negative of the thermoplastic and the urethane versus silicone is that we have a vertical stretch factor sometimes in the urethane and the thermoplastic elastomer that allows the prosthesis to piston up and down.
Mm.
So we got to give a little to get a little, right? We're gonna be very skin friendly with this material, but at the same time, it's going to create a vertical stretch in pistoning of the residual limb, which leads to less proprioceptive feedback, which is what we talked about earlier that we want to create with our patients in their prosthesis. It's good proprioceptive feedback.
Yeah, and so you say let's say
proprioceptive, so PRO.
So that allows more. It makes it easier for the patient because it feels like it's more a part of their body. Is that
correct? So sometimes I'll have a conversation with our patients of, for example, animals, cats, for example, their whiskers are their proprioceptors, where they are in space. And we as humans, we take consistent steps throughout the day, right? We know where our feet are going to land. That provides proprioceptive feedback for where we are in space and our environment. And the same thing happens with your prosthesis. The more we're able to contact that residual limb and the more that we're able to actually attach to that residual limb, the better proprioceptive feedback our patients are going to have with the use of their prosthesis, which is because then that means they're more confident during walking and activities outside of the office.
Yeah, and that's the ultimate goal. You want it to feel like an extension of their body, like it belongs.
That's right. So those are examples right there you're looking at of the different types of liners that we use. Top right corner would be the urethane. Bottom right corner would be the TPE or thermoelastic, and then top left corner would be the silicone-based material that we would use for our folks. And there's a number of different types of vendors and industry leaders in prosthetic components who make these liners. Those are really the three areas of materials that we use: silicone, urethane, and TPE or polyelastomer.
Okay. And these are replaced typically every how long do they last, or which does one last longer than another, or?
So great question. Patients ask this quite a bit. When we look at the silicone liner, which I told you earlier is what? More durable, less stretch, thicker, and less skin friendly, I should say. But what we get with that is we get a liner that's going to last a lot longer, can stand up to high activities. Mountain bikers, hikers, athletes will use this material for their prosthesis because, again, those features that it offers, it's going to have more longevity. With the polyurethane and the TPE, which is a thermoplastic elastomer. Those liners can last anywhere from 3 to 6 months is about the average for someone who's wearing their prosthesis throughout the day, around 6 to 10 hours a day consistent. That's what I typically find with our patients. Below the knee can run on the low end between 4 to 5 to 6 months, whereas above knee, we may get a little more longevity out of their prosthetic liners, just due to the weight-bearing surfaces on those aspects.
All right. Whoops. All right. So now we get into suspension. We talked about pin locking, you mentioned pin locking, the lanyard suction, and elevated vacuum. So a lot of words here, but show us and talk to us about the pin locking.
Sure. So and if you're out there watching this morning, one thing I want to iterate is that we're not covering all the suspension systems. I want to cover pin locking and suction and elevated vacuum here today, just to cover those two topics, because those are very popular in our industry and folks are always asking what's the difference in those two. So when you leave the conversation today, I would like for you to understand and be educated on what the difference is with pin locking suspension versus suction and elevated vacuum. So as we go into a pin locking system here, we could use any of the 3 liners for these features. The urethane is the least recommended for a pin locking system because it has the most vertical stretch. So, I talked to you earlier about the properties that this liner is made out of. This liner here has the most vertical stretch. All right. So we want to prevent vertical stretch inside of a prosthetic liner because it inhibits the way a patient is going to get proprioceptive feedback. So we're looking at a pin locking system, right? This is by far the most popular system that we use in prosthetics, especially below the knee, and especially with our newer amputees. Why? Because it's easy to don and doff and take off, or put on and take off. It requires minimal effort to get this on and off. So I'm going to show you today. As you can see, I've used another different type of liner here, and this is a TPE material as well. And as our patients will don or put on their prosthetic liner, you can see the pin distally here. And this pin is one of several different types of pins we use, but the point is that it's a pin locking suspension. Once your residual limb is inside the prosthetic liner, we then can don the prosthesis by the residual limb simply going down. You can probably hear that audible click there,
right,
engaging inside of the pin. And I'm showing you a socket here. Obviously, no foot, no components distally, but I want to reinforce the use of the locking mechanism here. So this is disengaged by placing your thumb on this pin release mechanism, which allows a residual limb to then be taken out of the prosthetic socket. I've used this specific type of socket this morning so you can actually see inside.
Right.
Adapts and works. So this is engaged again through the pin locking mechanism. What's key with this, again, as we talked about earlier, the vertical stretch, right? So as your patients are ambulating, you can see just how much vertical stretch. So a 3-pound to 4-pound below knee prosthesis that a patient is ambulating on, and throughout the day, they're weight bearing through here, and then they're actually picking up their prosthesis. So you can see the amount of travel that I have
right
with my hand. This is a prime example of pistoning that's happening inside the prosthesis. Overall, throughout the day, this can be an uneasy feeling for your patients, especially the new amputees. This can also create a lot of stress, a lot of residual limb issues that could occur as a result of this pistoning effect. The other aspect that that happens here is that the residual limb is going through this hydrostatic unloading feature. So what do I mean by that? You're putting weight through the prosthesis, and you're walking and lifting up the prosthesis. What that does to the residual limb is, if this is the residual limb, so this will be a below knee prosthetic, or residual limb, I should say, this actually will atrophy, get smaller throughout the day. So you can imagine you wake up in the morning, your prosthesis is consistently tight in the morning upon donning and doffing. Throughout the day of ambulating with the pin locking system, the residual limb gets smaller. So what's key and what's very important for our below knee amputees as well as above knee amputees is prosthetic socks, which we're going to talk about here in just a second. Prosthetic socks are important because they provide a mechanism to tighten up the prosthetic socket on the residual limb, but more importantly, to prevent weight-bearing issues that occur on the distal tibia, the patella, and the fibula head, as well as the lateral shaft of the fibula. So these are all aspects that we have to educate our amputees on, especially below the knee amputees. Obviously, we have more bony prominences to deal with and address, whereas above the knee, we have one bone, which is the distal end of the femur. Here we have two, and then we have bony prominences that are attached to that. Okay, so pin locking mechanisms. That's what we're talking about right now.
So just to go back to when you said in the morning the residual limb is larger, and then through essentially as you walk on your prosthesis, but then obviously through your residual limb, that pushes the water out. Is that what you mean by the hydrostatic? It pushes that water out, or you sweat, or what? Why does it shrink?
That's right. I like to describe this to patients as, for example, a balloon with water in it, right? When I squeeze that water balloon, this actually dissipates the water, gets it out of there, gets the fluids out of the residual limb. So you can imagine as you're walking around throughout the day on your prosthesis inside of this closed cylinder, what's happening is you're pushing those fluids out of the residual limb. When that happens, the residual limb is then relaxed and lying inside the socket, and you've got to make up that space with the prosthetic socks.
Oh yeah, because it's going to make it looser, right? So you're going to feel like it's going to fall off.
That's correct. So a lot of times newer amputees will come into my office to see us for a follow-up visit, and one of their first comments will be, I have a lot of bruising on the distal end of my limb. I also find that when I step with my prosthesis, my foot turns out or in. They may say to me, I'm having a lot of pain on my patella, which is right up in the kneecap area. And it is important, especially as a new below knee amputee, that we address these areas here. Patella, fib head, and distal end of the tibia on the anatomy. Those are areas that do not tolerate pressure at all. So those are areas that have to be dispersed and taking the pressure off of those bony prominences. We do that with your prosthetic socks by lifting the residual limb or creating a better environment for the residual limb to sit inside the socket. When we do that as clinicians, we're fitting that residual limb at the point it's at the day of the fitting. What's key for our patients is to understand and educate themselves that at the time of the fitting, but especially with a pin locking system, you may be a 3 to a 5 to a 7 or 8 ply upon leaving our office, which means you're wearing a 5 ply sock, which is 5 times thicker than a 1 ply, or you could be wearing 8 ply, a 5 and a 3. It's okay. You're a new patient, new amputee. We're learning how this process works. But as a result of that, that doesn't mean you're going to be an 8 ply tomorrow. I just had this conversation yesterday with a young man who's a patient of ours. He didn't quite understand why he's an 8 ply fit one day and the next day he's a 3 ply fit. But when you take into account that he does dialysis every other day, the volume, the fluid, if you're a patient out there and you go through dialysis treatments, you understand this conversation is that those fluids are pulled off the body during that dialysis treatment. As a result, your residual limb gets smaller. It's not visually smaller, but in a physical standpoint, it is smaller. You are actually measuring smaller in the residual limb. Therefore, you need to incorporate these prosthetic socks. And that is of top priority in education for new below-knee amputees, especially with the pin locking system.
So throughout the day, they're going to be putting them on, actually probably adding, correct?
That's correct. So initially in the morning, what you're going to find, especially as a new amputee, is that your limb is full of fluid, more swollen, more edematous. You're going to find it's just really kind of firm, and that's very consistent, normal aspects. You put your prosthesis on, you may go to the kitchen, you may walk down the hallway, you may even go out and about to check the mail. You come back in the house. I educate our patients, take your prosthesis off, check the fit of it right then. And one aspect I'd like to cover here, so as we go back to that locking mechanism inside, this is important and good education for patients. So if you're putting and donning and doffing your prosthesis on in the morning and you're putting it on, what you're getting is this typically. You're getting 1, 2, 3, 4, maybe that type of click through the locking mechanism. That's perfectly fine. That means we've got a nice tight fitting prosthesis that's conforming to the limb. What happens is this, I educate our patients. If you're putting your prosthesis on and you happen to hear this sound and you haven't started ambulating yet, that's not typically good, because if you haven't started weight bearing and you're already on the bottom of your prosthetic socket, especially in a pin locking system, that means you're distributing all 170 to 200 pounds, whatever your body weight is, through the end of the residual limb, the patella we talked about, the fib head on the lateral aspect. Again, we talked about those are bony, prominent areas that do not tolerate pressure. So we have to stay away from those. And the way we do that is throughout the day, like you said, is I educate our patients. We've created these bags for them to actually keep in their car that have their prosthetic socks. I tell them to carry these around just like a book bag, just like a backpack. That's what we educate a young man on yesterday, for example. And he said to himself, he was going out for a walk at the local park. He took his backpack of socks because he knew after ambulating 400 to 500 feet, he needed to check the fit. So those are criteria that we have to follow. It's important that we keep in mind how donning and doffing of the liner and incorporating the proper amount of socks.
Let me ask this question, Kelvin. So as you have that socket, you know, I think one of the visions that we have is that we are using the bottom of our limb, of the residual limb. So if I visualize it, I say, oh, well, I'm going to walk on the bottom of the residual limb, but the reality is that you want to fill up that whole socket. Is that correct? So that the weight is distributed evenly in multiple areas? Is that how that works?
That's correct. For below the knee amputees, I often hear, I've got to toughen up the bottom of my residual limb. I've got to get it calloused and hardened up on the bottom so I can walk in my prosthesis. And that was true 40, 50 years ago. But today with technology, it's so advanced. We use what's called total surface bearing sockets, patella tendon bearing sockets, hydrostatic unloading sockets. And as a result of that, we no longer have to be concerned with weight bearing on the residual limb at the very bottom where the amputation has occurred. I did an evaluation yesterday, and that exact topic came up. As a young man who's now a right below the knee amputee, is going to be weight bearing in his prosthesis, and his initial thought was, what do I have to do to toughen up the bottom of my limb so when I'm walking on my prosthesis I don't have pain? Well, not the point of wearing the prosthesis. That's not where we want your weight distributed, is distally on the very bottom. We do want you contacting on the very bottom, because then we create negative pressures if we're not contacting, which lead to other issues. But we want to incorporate a prosthetic socket, and this is where your clinician is important in educating and designing and performing their duty as a clinician to get you in the right type of socket. So with a patella tendon bearing socket predominantly in the patella area right below your kneecap. If you just grab your kneecap, go right below the kneecap, that's your patella tendon.
Oh, okay.
Tendon is where we rest if we're on our knees, painting a deck, working in our garden. That's what we're resting on, is a patella tendon. That tendon is very tough, resilient, can handle a lot of body weight. That's where we disperse the majority of your body weight in a patella tendon bearing prosthesis, or a PTB. We counterforce that in the back, or the popliteal, the hamstring area right at the knee area. Those two counterforce each other, right? So I provide a force here, and I provide a force in the posterior compartment right back here. We also load in the pin locking mechanism socket in the medial shaft, right? Just to the inside of your knee on the long bone here, which is your tibia, and then on the lateral shaft as well. And then we also, as I spoke of earlier, load distally on the anatomical limb. So those are all areas that we load in a patella tendon bearing socket, which is what we use predominantly with a pin locking system. So all of those aspects of anatomy are key for patients to understand. In fitting this prosthesis and fitting a patient with a patella tendon bearing suction elevated vacuum, it is important that the patient understand their anatomy and understand that they are not going to be a consistent fit every day of a 2-ply or a 3-ply or a 5-ply, especially initially after the amputation. And it is crucial that we educate patients on that.
So we talked about socks and the importance and changing those out and how that changes throughout the day. With a suction or elevated system or a vacuum system, are those? Do you have to have socks for those systems?
You do. Well, when we get into elevated vacuum here, we'll cover that. Research shows the industry standards for elevated vacuum and suction, especially, is to get rid of prosthetic socks.
Right.
But with that, we've got to have a limb that is somewhat stable, or that we can potentially stabilize with the use of a total surface bearing socket or a vacuum elevated socket, suction socket. That will help eliminate those socks. It also helps eliminate one aspect that we're going to talk about, which is pistoning, right? Because we have the volatility and the fluctuation of edema as a result of the pistoning inside of the pin locking system.
Okay. Anything else to cover on the pin locking system?
I don't think so at this time. I think we can move on to suction and elevated vacuum. I would like to iterate. It is important that not every patient will go into a pin locking system immediately after surgery. Not every patient will go into a socket, but never, I won't say never, but rarely ever will you put a patient into an elevated vacuum system after the surgery, especially with their initial prosthesis. It's just not clinically sound, and we're not going to put a lot of stress on that residual limb with an elevated vacuum socket.
Yeah, so you need multiple or several months down the road, or maybe even a year or two down the road before you've got a stable residual limb so that you could use that type of system.
For sure, for sure. I like to educate our patients in that a pin locking system, it's what's right for the patient sometimes, right? Some patients don't do well with elevated vacuum. Some patients don't do well with suction. Some patients like the pin locking mechanism because of the simplicity of it. And it works every day. It's consistent. It's a consistent fit every single day. And, I think I just want to iterate how important it is for the patients to have conversations with their clinicians about, why am I getting a pin locking system versus a suction versus elevated vacuum versus a lanyard system, which we're not talking about today, but is a popular system for above knee amputees as well. Have a conversation with your clinician about that.
Yeah, excellent. Okay, so let's talk suction suspensions.
Sure. So as we go into suction suspension today, I like to find for below knee amputee suction suspension a somewhat stable limb. I also would like to iterate that for a new below knee amputee who's coming in for initial consult in our office for a prosthesis, I will sometimes put that patient into a suction system as well if they have a nice bulbous limb. So when we have a bulbous limb, it's very difficult to get that limb inside of a prosthetic liner to then engage in the pin locking system.
Yeah.
Because one of the disadvantages of having the pin is that if we can't get this pin to line up on the distal very end of the residual limb, it's hard for our patients to engage this lock. And if that pin is not engaging, that can make for a frustrating morning.
Yeah.
When you want to get out and go for a walk, or just get out of the house and enjoy walking again for the first time, right? So I will use, again, a suction system for a nice bulbous, really full of fluid residual limb. We'll use suction for that if you're a new amputee. But to get down into suction, what does it consist of? Suction is a way that we suspend the prosthesis on the patient's residual limb, because we talked about earlier proprioceptive feedback. Patients like that. Suction has shown with research, suction, elevated vacuum to increase proprioceptive feedback, because we're touching more of the residual limb, we're contacting it, we have a more intimate fit with a suction socket. As we talked about with the pin locking system, we have pistoning, we have tissue that's being extrapolated away from the socket, and so your socket becomes loose, it rotates. We prevent and eliminate all of that with a good, properly fitting suction socket, elevated vacuum socket. We also eliminate the socks, right? That's the point of the suction system as well. So we increase proprioception, we eliminate the use of socks, hopefully. That can sometimes take multiple sockets to get you there, but that's the goal. And then we increase the amount of proprioceptive feedback. Along with that, a disadvantage is that we sometimes have to wear a secondary liner for suspension, and we sometimes have to become educated on the donning and doffing process with the suction system.
Yeah, do you have an example of a suction system so that we can take a look and see how that works?
I do. So I want to cover with our audience today a couple of different suction suspension mechanisms. So here we have a cylinder liner, and the seal, I think it's on my next slide here.
Okay. Oops. Go back to that.
Yeah, there we go. Perfect. So this is just an example of suction. What I want our audience to understand is there's a number of different types of suction systems out there. What is the point of suction? Definition is that when you go into your prosthetic socket and the residual limb is actually going down into the socket, we want to expulse all of the air out of the socket, right? The suction is created by not letting the air come back into the prosthetic socket. That is suction in a very generic definition. We're expulsing the air out that's created as a residual limb goes into the socket, and we're not allowing it back in. The suction is created that way. Therefore, we create a closed contact system inside the prosthesis. We eliminate pistoning as a result of that. I've brought an above knee socket here today. And again, I've used a broad material, and it's called a thermalin clear material that allows us to see once the residual limb. So here's our prosthetic socket. Here is our suction liner. The residual limb is placed down inside the prosthetic socket. Once the residual limb goes down into the socket, as you can see here is a one-way valve. This is where my air is expulsed. I have a mechanism here that I'm able to allow the patient to put back into this hole here, which allows the air to be extrapolated but not come back into the prosthesis. It then activates this button release mechanism to allow air to come back in through this porthole, which releases the suction. And as you can see on the screen, the seals are what are created through and around the prosthetic socket in this area. And so actually when you're wearing this system, it's a really neat system for above knee amputees, I think, especially because your suction is created from here down distally. There's also elevated vacuum, which we'll cover for above and below knee amputees. It can be kind of sophisticated, a little more advanced for above knee amputees. Works really well because, again, we're trying to create that environment where proprioceptive feedback is at its highest. So this system is good. I like it for new above knee amputees because we can squeeze more tissue. We can manipulate that residual limb a little easier for above knee amputees. I don't like to use this type of suction system for below knee amputees unless they have a nice bulbous limb, again, like we talked about earlier, or a lot of tissue. So someone with very low body fat, for example, and they're a below knee new amputee, active 20-year-old, for example. It can be kind of difficult to use suction with them initially because we have anatomical crevices that we're trying to fill due to low body fat. They're very prominent. We also have different suction liners, though, that come actually from the same company that produces this liner that will allow us to move the seal distal and vertical. So we can move that seal up and down to create the seal where we want it to be, which is another caveat and another positive for suspension. We can move the seal from distally here up to proximal.
So it seems, Kelvin, that system would minimize pistoning. Is that one of the big benefits?
That is correct. That is one of our main priorities. Another suction system here I've got. So as you can see here, I brought in two other liners. You can see the rubber seals here and here. And again, same type of suction system that's created. The seal is created here with the rubber seals on the liner, as you can see. It does. That's one of the top priorities of going into suction, is to minimize pistoning up and down vertically inside the prosthesis. So that's what we're able to eliminate with this. Also, I want to iterate on the residual limb. It is key that we don't have any skin breakdown, obviously, with a new below and above knee amputee. And suction, actually, for above knee amputees and below knee amputees for that matter, sometimes they can be very sensitive on the distal residual limb. Some folks may have a skin adhesion, or where the scar is actually healed to the bone, or they may have had a wound back. They may have had a 6 to 7 month healing period because they didn't heal immediately after surgery. And as a result, they may have some scar tissue built up on the distal end of the limb where the amputation occurred. It could be very sensitive. It could break down very easy. Those are other aspects we have to look at as clinicians to see if that patient would do better with suction suspension versus pin locking suspension. Because again, the pin is actually extrapolating that tissue, putting more force distally on the residual limb. So suction that's another positive of using suction.
Okay. All right, excellent. Anything else to cover with suction?
I will iterate that suction does require good dexterity from a hand mechanism from your fingers to get the gauge if we have to. We can incorporate a distal valve. What I mean by that is on the socket. If this were below the knee or above the knee for that matter, as this is, we could put the valve distally here, and we could use a mechanism that would actually allow the air to expulse and then close back up immediately by itself on its own, which is a very good suction mechanism to use for folks who have poor dexterity. We eliminate the use of the valve by doing that. So there's a number of different ways that we can suspend suction mechanisms on the residual limb. That's a conversation to have with your clinician.
Okay, excellent. Oh, here we talk about where that vacuum seal occurs.
That's right. The suction liner has, as you can see, this cylinder liner here just shows you an example of how it bonds to the prosthetic socket and creates a closed environment for the suction mechanism to occur. And these are examples here of suction with the valve. As you can see, these are two below the knee prostheses. The valve on the left side, you can see the valve is on the very bottom where the cylinder liner is, and on the right side, we have a pin locking mechanism. And it just gives an example of a clear of each. It shows you how those are activated.
Okay.
So let's talk about elevated vacuum. That is a hot topic, has been for a number of years. It has a lot of advantages. The disadvantages I don't really count as disadvantages as much as the feedback it offers. So in other words, with the positive effects that it has on the residual limb and the patient outcomes, I think far outweighs the disadvantages, which are they can be a little more expensive. Components, I sum it up to our patients like this. If we have a car with a lot of bells and whistles, then we have a car that has the potential to have more issues, right? Where these things have to be replaced. Industry and vendors in our industry have created components that no longer are breaking down as easy. So in other words, the elevated vacuum systems work very well with a lot less maintenance in today's world, which is a good thing because the patients then don't have to deal with all these bells and whistles that are breaking down and breaking apart and have to be replaced periodically. So the industry has done a great job with elevated vacuum and creating a prosthesis that has very minimal maintenance now, but still creates that elevated vacuum. So what do I mean by elevated vacuum? So we talked about earlier with a suction socket, and the air is expulsed out of the prosthesis with the use of the suction socket system. We showed here, we have a valve where the air is expulsed.
Mm-hmm.
Elevated vacuum, what we have is there is a mechanical pump or an electrical pump that is actuated into the prosthesis that actually extrapolates air continuously, right? As a vacuum does. So it's constantly removing air, any voided air, but it's also creating a system where the walls of the residual limb, the tissues of the residual limb, the prosthetic liner is actually pulled against the wall of the socket of the prosthesis. As that's pulled against the wall of the prosthesis, we create the maximum proprioceptive feedback we can inside of that prosthesis. Why is that important? Because it feels even more like it's part of the patient, right? It's like it's their old leg, for a lack of better terms, that's back. That's what I hear my patients say sometimes. I feel like I've got my leg back, because they feel like they're not going to lose the prosthesis because it becomes disengaged as what has a tendency to happen with pin locking systems. And we've eliminated all pistoning, we've eliminated all rotation, we've eliminated the chances of residual limb breakdown due to those rotational aspects that happen in a pin locking system. So that elevated vacuum, in a quick and a synopsis of how that works, but we're going to talk about it. There's a couple of different systems here I've got that we're going to show. Okay.
You mentioned, I want to go back to something that you mentioned earlier. You had said that it was better for the residual limb. Can you explain what you mean by that?
Sure. So our folks, and I'm sure if clinicians are watching, we're all familiar with HBO chambers, right? Hyperbaric oxygen chambers that help at wound centers. They help wounds to actually heal. Where there's research behind elevated vacuum that will actually pull tissue out, right? To get blood flowing, we increase circulation and we increase oxygen flow to the residual limb with the vacuum. The research has been done. And so actually with a vacuum locking or suspension system, elevated vacuum, research has actually shown to help heal wounds on the residual limb. And there's multiple. We could get very detailed into that one day if we get feedback and folks have questions and want to know more about elevated vacuum and how it can help with wound healing. That's a great conversation to have, because it is out there to where elevated vacuum actually helps small ulcerations, skin breakdown to heal, because we're forcing the residual limb to actually, for lack of better terms, and so folks can understand it, is to actually open up the vessels.
Yeah.
When we open up the vessels in the lymphatic tissues, it forces them to fill with oxygen and blood flow. As a result, those wounds are now going to help to heal properly inside of a vacuum locking system. or
Okay. So yeah, I know for me when I think about vacuum versus suction, I'm like, well, that's the same thing, isn't it? I mean, that's probably a natural thing for a person to consider. But we talk about suction, it is there's nothing that's mechanically happening to create an increase in the vacuum level. So as I understand, and tell me if I'm understanding this properly, one of the so if we use suction, we're going to get that initial good connection, but then over time, as our residual limb shrinks, then it creates space, and there's nothing that's going to get that. There's no mechanism that's going to continue to maintain that level of vacuum that you first or initially are able to achieve when inserting your residual limb. Is that?
that's correct. With suction, we still have a high chance likely of having to use prosthetic socks because with suction, again, we're pressing the tissues against the walls of the prosthesis
Yeah.
and we're bearing through the prosthesis. And therefore, the tissue, the residual limb is going to be under pressure and it's going to atrophy throughout the day. Okay. With elevated vacuum, we have the effect of where it's actually pulling and extrapolating the tissues of your residual limb against the walls of the prosthesis. Hence, that's why with elevated vacuum, we like to use the urethane liner. Elevated vacuum does really well with the urethane liner, and this is made by a company based out of Germany. They have U.S. headquarters as well with Autobach. There's a number of different companies now who have ventured into vacuum systems. But with this specific one, they were kind of the genesis of the vacuum elevated sockets. The urethane flows, as we talked about earlier, it has a flow factor at the molecular level. It thins out, right? So as I'm pulling those bony prominences against the walls of this liner and it's thinning out, it actually allows the prosthesis and the manual vacuum that's here, the mechanical vacuum, to pull the walls of the tissue against the walls of the socket. So therefore, we decrease the amount of socks we're having to wear because we're not pushing against the residual limb, we're actually pulling away from it, right? Which is causing blood to flow, oxygen to flow, to heal the wounds that may be there in the residual limb, but also create that maximum proprioceptive feedback. So as you can see inside this prosthetic socket, hopefully you can see down in here just a little, there's actually a porthole in the very bottom of this prosthetic socket that has been drilled in. Here we have the mechanical vacuum. How does this work? This is actuated by the patient putting their weight through the prosthesis, and this mechanical vacuum is then moving vertically in the area as the patient is walking up and down, which is creating the vacuum, which is pulling the air distally right out of this hole in the bottom of the socket. If there's a negative or a disadvantage of wearing elevated vacuum, it's that we have patients who have to use the secondary suspension sleeve, which is here, all right? We pull this up. So you have someone who's wearing elevated vacuum. They have the liner on their residual limb, and then the residual limb is going down into the prosthetic line or prosthetic socket. That's then rolled up by this suspension sleeve on the residual limb, which creates a closed environment for the vacuum to actually work. So as the vacuum is pulling air, I actually test and know and educate our patients on, you've got a good fitting vacuum system when you can see the imprint of your prosthetic socket through your suspension sleeve. That lets you know we've got maximum vacuum. With elevated vacuum, again, some folks will say, well, how does it work? How many different systems are there? Autobach, for example, has multiple elevated vacuum systems that work. Four specifically, I think they're on my next slide here. You'll go to that for me, Russ. As we're talking about elevated vacuum systems, you see the second one here in your screen. It's called the P4, and then the E2 on the very back side there. Those are two of the more popular ones I like to use because the P4 is a manual pump that doesn't have any bells and whistles. You simply put the prosthesis on, the vacuum works for you. You can't see from the picture here because it's a still picture, but again, it is a mechanical vacuum where you're walking and it's mechanically pulling and extrapolating the air out. The E2 pump, the purpose of showing you this elevated vacuum style here is that this is an electronic pump. And again, it would be great to have a conversation with folks, maybe another Facebook Live, where we could specifically talk about how the E2 or electrical pumps work, right? That are manually operated by the patient. They control the amount of vacuum from 5, 10 to 15 pounds of pressure and vacuum PSI that is extrapolated from the prosthesis. Whereas the P4 is manually operated. You put it on, you start walking. After about 4 to 5 steps, you actually feel the vacuum pulling you in. If there's a disadvantage of the E2 versus the P4, it's that the E2 is electronic, right? It's electric. And with that said, you have to charge this pump every night.
Mm-hmm.
Even though it lasts 24 to 48 hours without charging, I recommend to our patients is lithium-ion batteries. You charge it every night, just like your cell phone. But the pump works the same. It's the same mechanism. It's the same methods. It's just a different message of getting it to the patient in their residual limb.
If you're an above knee or below knee, does one of these systems, would it be preferred over the other, or doesn't matter?
These are specific to below the knee, these elevated vacuum systems. It would be difficult today in our conversation in such a short time to cover actually what it is with above knee elevated vacuum.
Okay.
It is a very complex system. It's easy for clinicians to understand and work and activate. It takes a lot of experience for your patients to be acclimated to it, to be educated on it, but it works really well. Got to have the right residual limb. And so that would be a great conversation for above knee amputees who are interested in elevated vacuum for above the knee prosthetics and how that works and what the differences are. But with all that being said, it's still that same message, is that we want to create an environment that has great proprioceptive feedback. And that's what elevated vacuum offers. It helps with wounds to heal if you have those on your residual limb. It has great proprioceptive feedback. We eliminate pistoning. We eliminate rotational issues that happen in a prosthesis in a pin locking system. And we eliminate the use of prosthetic socks. So you asked a question earlier, do we get rid of socks with elevated vacuum? Yes, in a perfect world, we would. You wouldn't have to wear any prosthetic socks. The fact of the matter is that your residual limb, if you're a below knee or above knee amputee, is going to change over a period of time. We can't stop that. We can't prevent it. It's just a phenomenon that happens. With that said, the vacuum system certainly eliminates the amount of socks that you would have to wear. So eventually, we're going to have to replace your prosthetic socket due to atrophy, because as I like to summarize to my patients, eventually the tires wear out on the car and we got to replace the tires. The key here is that we're going to have a car that the tires don't wear down as fast, right? And so that's the key to everything here. We have a prosthetic socket that we have to replace eventually because of atrophy. But with that said, we certainly eliminate the amount of socks you're having to wear as a patient. And distally, so the bottom half of the residual limb is where we have prosthetic socks with a vacuum system. So the fit of an elevated vacuum system is certainly more intimate and certainly more intricate in the fitting. That's why it is important that you have a very mature, stabilized tissue and limb before we go into an elevated vacuum system.
Excellent. Oh, this is all great.
Hopefully this is good education for patients to learn about pin locking, suction, and elevated vacuum. And again, we just scratched the surface. I mean, we could dive very deep into these conversations, but I think today more is to educate patients on an overview of these systems and why you may be a candidate, why you may not be a candidate for vacuum and elevated vacuum.
Excellent. So we will come back. We'll have many more of these Facebook Lives as we discuss um, various nuances in the different systems, care strategies for our patients. We also have the amputee support group is a great network for amputees to learn more about. You can get all of that information at poibelieve.com. And we are located, so we are the Prosthetic and Orthotic Institute. We're located in Rock Hill, Pineville, North Carolina. So Rock Hill, South Carolina, Pineville, North Carolina, and Lancaster, South Carolina are our locations. Kelvin Jones is one of the owners and a lead clinician. My role is I call it the Chief Inspiration Officer. So really, I think it's to ask questions all the time is my role. So we are grateful for all of our patients, for all of our referral sources. We encourage you to ask questions. My email is russ@poibelieve.com if you have any questions at all. You could also reach out to Kelvin@poibelieve.com. We are here to serve you, answer questions, and get you back up and going. Anything to add? All right. Everyone have a fantastic day. Thanks for taking the time. Thank you, Kelvin. We'll see you soon, bud.
Thanks for hosting, Russ.
Absolutely. My pleasure.